Hello and welcome to Cardiovascular Anatomy. In this lecture, I will cover just the specifics of the cardiac and vascular structures associated with the heart. This lecture will also cover structures of the thorax in which the heart is contained. Additionally, I will provide you with chapter links within this lecture which will allow you to jump to important sections within this presentation. Find the links in the description below. Read this carefully. These are the objectives of this particular presentation. The mediastinum is a division of the thoracic cavity. It lies between the right and left pleura of the lungs and near the median sagittal plane of the chest. From an anteroposterior perspective, it extends from the sternum in front to the vertebral column behind and contains all the structures which we call the thoracic viscera, except for the lungs. It is surrounded by the chest wall anteriorly, the lungs on each side or laterally, and in the back by the spine. The mediastinum is continuous with the loose connective tissue of the neck and extends inferiorly onto the diaphragm on which it is anchored. Thus, the mediastinum is the central compartment of the thoracic cavity, and it contains the heart, the great vessels of the heart, the esophagus, the trachea, phrenic nerve, cardiac nerve, the thoracic duct, the thymus gland, and lymph nodes of the central chest. To re-emphasize, it is important to realize that the lungs are extramediastinal structures, which means it is not contained within the mediastinum, but rather outside of it and bounds laterally on each side of the mediastinum. The mediastinum is a clinically important cavity. It can move from its central location under abnormal circumstances and will show on a chest X-ray. This movement can be expected under certain circumstances and may or may not require urgent, usually surgical attention. If this movement occurs too suddenly and too fast, it can end up moving the heart from its location in the mediastinum and thereby lead to the development of life-threatening arrhythmias. An entry-level practitioner should be able to visualize a chest X-ray and be able to tell a shifting of the structures within the mediastinum. So, in effect, a mediastinal movement from its usual position is referred to as a shift or otherwise called a mediastinal shift. As I mentioned, it is an important consideration in examination of the chest X-ray. In patients who have air trapped in the pleural space or after the removal of a lung. Entrapped air in the pleural space is called pneumothorax, and a removal of the lung is called a pneumonectomy. When air enters the pleural space due to an entrance wound on the chest wall, it is called a tension pneumothorax. When the lung is removed on a given side, again it is called a pneumonectomy. These abnormal circumstances, along with certain other conditions, can cause the mediastinum to shift, and usually there are indicators as to which side it will shift to. We will talk about that more as we go forward and talk about pathology. However, just for an example, if there is a tension pneumothorax, for example, if there is air sucked into the pleural cavity due to something like a stabbing wound, in that case, the air in the pleural cavity will push the lung away from the chest wall, and thereby it will push the mediastinum towards the opposite side. The mediastinal margins are demonstrated in these two images. Uh, the upper margin of the mediastinum is a plane that goes from the first rib to the first dorsal vertebra. The inferior margin of the mediastinum is the diaphragm and is situated below the mediastinum. Laterally, the mediastinum is bounded by the pleura or the pleural margins. In front of the mediastinum, you have the sternum, and behind the mediastinum, posteriorly, is the anterior surface of the dorsal vertebra. The mediastinum itself is divisible into two major segments: the superior segment or the superior division of the mediastinum, and the inferior segment, which is the inferior division of the mediastinum. The inferior division of the mediastinum can be further divided into three compartments. There is the anterior compartment, the middle compartment, and the posterior compartment. Let's look at the contents of the superior mediastinum first. The superior division of the mediastinum is bounded anteriorly by the manubrium sterni. In the back, there is the T1 through the T4th vertebra. The sides of the superior mediastinum is bounded by the mediastinal pleura or the medial side of the pleura. On top of the superior mediastinum is the plane of the thoracic inlet. And inferiorly, you have an imaginary line joining the sternal angle or the angle of Louis with the lower border of the T4 vertebra. The contents of the superior mediastinum is shown on the image to the right. There is the trachea and the thoracic duct at the top, and then you have the right vagus nerve and the left vagus nerve. You have the left subclavian artery with its branches, the brachiocephalic artery, then the right phrenic nerve and the left phrenic nerve, and the right brachiocephalic and the left brachiocephalic veins, uh, along with the thymus in the front, which is a organ of the immune system, and then you have the arch of the aorta and the presence of the esophagus in the back. So these are the contents of the superior mediastinum. As noted earlier, the inferior mediastinum is divided into anterior, middle, and posterior mediastinums. The anterior mediastinum contains lymph vessels and lymph nodes, the internal mammary veins and arteries, and in children it may also have the thymus, which actually has a variable position depending on age. Uh, The boundaries of the anterior mediastinum include the superior horizontal plane, as shown in the image. Inferiorly, it has the diaphragm. Anteriorly, it is bounded by the body of the xiphoid process of the sternum. Posteriorly, you have the middle mediastinum, which contains the heart. The lateral portions of the anterior mediastinum are bounded by the lungs and the pleura. And as mentioned, it may contain the thymus gland and the lymph nodes. The middle mediastinum of the inferior mediastinum is bounded anteriorly by the pericardial layer of the heart and posteriorly by the posterior parietal pericardial layer. The contents of the middle mediastinum are extremely important. As you can see, it contains the heart and the pericardium, the ascending trunk or the ascending aorta, the pulmonary trunk, the superior and inferior vena cavas, the right and left pulmonary veins, and right and left phrenic nerves, and the lymph nodes. The the middle mediastinum, therefore, is what contains the heart. The posterior mediastinum contains the descending aorta, the thoracic portion of the esophagus, the posterior intercostal arteries and veins, the middle esophageal arteries and veins, the azygous vein, the hemiazygous vein, and the accessory hemiazygous veins. The left and right vagus nerves are respectively located in the front and behind the esophagus. Other structures in the posterior mediastinum include the ganglia of the thoracic sympathetic system. The thoracic duct and other lymph nodes are the most important lymphatic elements in the posterior mediastinum. In physiological conditions, the lymph nodes of the mediastinum have a diameter between few and 20 millimeters or less. They can increase for infectious or oncologic, uh, that is, cancer diseases, and it can be anatomically classified by the mediastinal lymph nodes currently used by the International Association for the Study of Lung Cancer. The heart is a central organ of the middle mediastinum and is approximately 250 to 300 grams, or approximately the size of a closed fist of the individual. It is situated 1/3 to the right of the midline and 2/3 to the left. It is situated exactly behind the sternum, so it is you can call it a retrosternal organ. And the heart is expressed as an inverted pyramid, which means it is a pyramidal structure. However, the pyramid in this case is an inverted pyramid with the base at the top and is related to the second intercostal space and the superior surface across the atria. The apex of the heart, the apex is pointed downwards and it projects left into the fifth intercostal space at the midclavicular line and is obliquely directed anteriorly and to the left. Therefore, the apex of the heart is tilted up towards the chest wall such that when it contracts, it hits the chest wall. Surface anatomy is a very important concept in medicine. It is related to the surface representation of organs or viscous as as it relates to the surface of the body. This helps us in examination and understanding pathology when there are changes in physiology. Therefore, to understand the cardiac surface anatomy, let's look at where we can expect the apex, the right border, and the left border from the surface of the body. The apex of the heart is at the fifth or sixth intercostal space, medial to the mid-clavicular line. The right border of the heart is 1 centimeter to the right of the sternum, within the third through the sixth intercostal space. The left border of the heart is 1 centimeter left of the sternum at the second intercostal space, then diagonally to the apex, which is situated at the fifth to the sixth intercostal space in the midclavicular line. So note the relationship of the arch of the aorta, that is the principal artery arising from the heart, in relation to the skeleton. It rises up from the base of the heart and goes backward and downwards between the heart and the spine. The area through which the arch of the aorta is shown here travels through the superior mediastinum and then into the posterior mediastinum. We will now look at the mediastinal spaces before we delve further into the structure of the heart. The cardiac tissue is in three layers. There is a pericardium, there is a myocardium, and then there is an endocardium. Let's look in more details at that. The heart is covered by a structure called the pericardium. Dr. Hillegas refers to this covering as a layer of the heart itself. But this is a covering of the heart and not the heart itself. This pericardium is a bilayered structure as shown in the picture here, with a thick white space with a blue outer border and a yellow inner border. The outermost layer of the parietal pericardium is a tough, fibrous layer of dense connective tissue. This connective tissue is irregular, that gives it immense strength in every possible direction. The inner surface of the visceral pericardium is just a folding of the parietal pericardium. The parietal pericardium folds in and creates a bilayer similar to what we see in the pleura. So it's a continuous structure, but the composition of the inner layer is different. This inner layer of the pericardium is called the visceral pericardium because it contains the viscera. The viscera is an organ contained within an enclosed space. The viscera in this case is the heart. So the visceral pericardium is the inner layer of the pericardium, and it is a thin, smooth, moist, serous layer, and it is also referred to as the epicardium. The pericardium is anchored to the diaphragm inferiorly, and it blends with the connective tissue of the great vessels on the superior side. Now, between the parietal and visceral pericardium is a space. We call this a potential space. That means that it is capable of expanding under abnormal circumstances. However, it is a space that is separated by 10 to 20 milliliters of clear pericardial fluid that allows the surfaces to glide without allowing it to separate. There are many clinical correlates of this information. The presence of the minimal amount of fluid secreted by the visceral pericardium to allow it to glide makes the movement of the heart easier with less friction. Whereas in abnormal circumstances, the pericardium can get inflamed and lead to oversecretion of fluid that accumulates in this pericardial space, and this accumulation can only so far stretch the outer pericardium. The reason for the lack of stretchability is that it is a fibrous, tough, fibrous sheath. Therefore, the fluid accumulation will compress the inner structure, and that means the heart itself. And this will prevent the heart from beating. Depending on the amount of fluid that accumulates within this space, and this fluid can be not just the pericardial fluid, but it can be blood or similar blood and other types of fluids. Regardless, this fluid, because it cannot stretch the parietal pericardium, it will compress the heart and prevent it from beating and eventually causing it to stop. This is therefore a medical emergency, and it is called cardiac tamponade. It must be relieved by surgical intervention where a window is cut out from the parietal pericardium to allow the fluid to escape. Inflammation of the pericardium can also cause pain and restriction of cardiac movement without the accumulation of fluid. There are characteristic auscultation sounds which can be heard over the inflamed pericardium and corresponds to the type of chest pain that a patient reports. This can suggest diagnosis and help with urgent medical attention. The middle layer surrounding the heart is called the myocardium. So the heart is contained inside the pericardium, but it is not the same as the pericardial cavity, which is the potential space between the parietal and the visceral pericardium, which we discussed in the previous slide. Instead, the heart is contained inside the bilayered pericardium. The visceral pericardium is in direct contact with the heart. This visceral pericardium is shown in the picture, and it's also called the epicardium. The myocardium is the actual heart muscle inside the epicardium. It is the thick muscular element of the heart in direct contact with the epicardium or the visceral pericardium. It consists of contractile cells, which are called myocytes, which facilitate the contraction of the heart. These myocytes are unique as they demonstrate three unique traits. The first unique trait is called automaticity, which means that they are able to contract in the absence of any external chemical or neurological stimuli. The second unique trait is rhythmicity, which means the ability to contract in a rhythmic manner. And the third unique trait is conductivity, which is the cell's ability to transmit nerve impulses. Now, myocardial cells may be categorized into two groups based on their function. One of them is the mechanical cell, which contributes to the mechanical contraction uh, of the muscle. And the second type of cell is called a conductive cell, which contributes to the flow of electrical current through the muscle. The mechanical cells are the ones that are called myocytes, and these are large cells containing a large number of actin and myosin microfilaments, which enable a greater capacity for mechanical shortening needed for the pumping action of the heart. In addition, these cells have a large amount of mitochondria, which is approximately 25% of their entire cell volume, so that it can provide sufficient energy in the form of ATP or adenosine triphosphate to the heart, uh, which is a muscle that can never rest. The conducting myocardial cells are joined together by the presence of so-called intercalated discs. These intercalated discs join two continuous cells together, and this is called a syncytium. Now, the word syncytium is perhaps new to you. It means a group of cells in which the protoplasm of one cell is continuous with that of the adjacent cell. Now, the intercalated discs contain two types of junctions. The first type of junctions is called a desmosome, and a desmosome attaches one cell to another. Uh, and the second type of connection or junction present within the intercalated disc is called a connexin, or connexin. The connexins allow the electrical flow to spread from one cell to another. These two junctions work together to move the impulse through a very low resistance pathway through the muscle. A clinical tip here is to remember that myocardial cells are highly evolved structures in the animal kingdom. The basic rule of thumb in the animal kingdom is more evolved a structure, an injury to that structure may not allow the cell to regenerate. Therefore, injured myocardial cells cannot be replaced, as the myocardium is unable to undergo mitotic activity. Therefore, if these cells die from a lack of blood supply, which is called infarction, or if these cells undergo weakening due to a pathological process called cardiomyopathy, then the heart muscle's ability to contract is significantly reduced and may not be able to be strengthened back by any significant means. The innermost layer of the heart is called the endocardium. This layer consists of a simple squamous endothelial layer overlying a thin areolar tissue layer. The tissue of the endocardium forms the inner lining of the chambers of the heart and is continuous with the tissue of the valves and the endothelium of the blood vessels. So it is the same endothelium from inside of the heart into the blood vessels, including arteries and veins. The external structures of the heart and its layers are summarized in this slide and can be remembered by the mnemonic PEP MEND, and you can see how it goes from the pericardium to the epicardium, the myocardium, and the endocardium. The heart is the principal pump that circulates blood throughout the entire vascular system. The heart is closely related to the size of the body and is roughly the size of the individual's closed fist. It lies obliquely or diagonally in the mediastinum with two-thirds lying left of the mid-sagittal plane. The superior portion of the heart is formed by the two atria, and then it is called the base of the heart. It is broad and exists at the level of the second intercostal space in adults. The apex of the heart is defined by the tip of the left ventricle, which projects into the fifth intercostal space in the midclavicular line. The heart is therefore an inverted pyramid with the base at the top and the apex at the bottom. Additionally, the heart is rotated in the mediastinum such that the right side is anterior and the left side is posterior. The heart moves freely and changes its position during its contraction and relaxation phases, as well as during breathing. As the heart contracts, it moves forward and collides with the chest wall. The portion of the heart that strikes the chest wall is called the apex of the heart and is termed the point of maximal impulse or PMI. Normally, this point is evidenced at the anatomic landmark of the apex, which is the fifth intercostal space in the midclavicular line. In pathological conditions, this PMI can move and usually laterally towards the lateral side of the midclavicular line. In terms of ventilation, quiet resting breathing does not alter the point of maximal impulse because of minimal excursion of the diaphragm. However, with deep inspiration, there is more significant inferior depression of the diaphragm, causing the heart to descend and rotate to the right, displacing the point of maximal impulse away from the normally palpable position. As mentioned, a clinical tip again is that the PMI is relatively more lateral in patients with left ventricular hypertrophy, which is a pathological condition, and it is caused by an increase in the mass of the left ventricular wall. Also, patients with pneumothorax, which is presence of air in the pleural cavity, and and therefore will experience a shift of the mediastinum and relative altered PMI in those patients. Note the schematics of the heart from figure 116 of Hillegas's text, which has been reproduced here. This schematic information is for you to reference as we discuss additional points of the heart's structure. The heart is divided into a right and left half by a longitudinal septum that is shown in the figure. The right side of the heart receives blood which is deoxygenated from the rest of the body. Therefore, it is venous blood. And the left side of the heart receives the oxygenated blood returning from the lungs. Each half of the heart is made up of two chambers. Uh, on the top, there are the atria, so there is a left and right atria. And on the bottom, there are the ventricles. Therefore, there are the left and right ventricles. The four chambers of the heart include therefore right atrium and right ventricle that forms one portion of the heart that supports pulmonary circulation, and then the left atria and the left ventricle support systemic circulation. The right atrial chamber consists of smooth posterior and medial inner walls. Parallel muscle bundles known as pectinate muscles exist anteriorly and laterally. Both right and left atria have small ear-like projections or extensions called auricles that come around the front. They help increase the volume of each chamber. The right atrium, the right atrium receives blood, which is deoxygenated from three major vessels. That these vessels are the superior vena cava that collects venous blood from the head and upper extremities. The other vein is the inferior vena cava, the inferior vena cava that collects blood from the trunk and the lower extremities. And finally, the coronary sinus collects venous blood specifically coming from the heart itself. So as a tissue, the heart needs its own blood supply, and therefore it receives blood by specific arteries, and these arteries will have to also the used blood will also have to return into the veins for purification, and that is the coronary sinus. So the coronary sinus empties into the right atrium above the tricuspid valve. The normal diastolic pressure to enable filling ranges in the right atrium go from 0 to 8 millimeters of mercury. So to fill blood into the right atrium, we need blood pressures of 0 to 8 millimeters of mercury. Clinically, this is a very important hemodynamic parameter. It is referred to as the central venous pressure, or CVP, and this is what's used to understand whether there is sufficient blood returning into the right atrium to be able to supply the left side of the heart, and thereby sufficient blood to go out to the systemic circulation. The right ventricle is shaped like a crescent or triangle, enabling it to eject large volumes of blood through a small valve into a low-pressure pulmonary system. Blood within the right ventricle is received from the right atrium through a one-way valve present between the atrium and the ventricle and is called the tricuspid atrioventricular valve. It ejects blood to the lungs via the pulmonic or pulmonary valve, which is a semilunar valve, and ejects it into the pulmonary artery. So blood coming to the pulmonary ventricle from the right atrium into the right ventricle is going to eject the blood into the pulmonary artery. The pulmonary artery is what carries the blood from the heart to the lungs for oxygenation and getting rid of carbon dioxide. The right ventricle, like the right atrium, may be considered in two parts: a posterior inferior inflow tract, which is termed the body, which contains the tricuspid valve, chordae tendineae, papillary muscles, and trabeculated myocardium. And number two is an anterosuperior outflow tract called the infundibulum, from which the pulmonary trunk arises. Four muscular bands separate the inflow and the outflow portions of the right ventricle, including the infundibular septum, the parietal band, the septal band, and the moderator band. Pressures within the right ventricle are relatively lower compared to the left ventricle, with diastolic pressures ranging from 0 to 8 millimeters of mercury and systolic pressures ranging from 15 to 30 millimeters of mercury. During periods of exacerbation, patients with chronic lung pathologies, including COPD and pulmonary fibrosis, often present with low oxygen content within the blood called hypoxemia and an increased pressure within the pulmonary vasculature. This is called pulmonary artery hypertension, or also pulmonary arterial hypertension, which is abbreviated as PAH. So this is caused by compromised perfusion capacity to the lungs. The increased pressure within the pulmonary artery increases the workload on the right ventricle, causing a failure that is specific to an underlying lung pathology. This is called cor pulmonale, or right ventricular hypertrophy, and resulting right ventricular failure. So one more time, the specific condition called cor pulmonale is a description, or is a terminology that describes right ventricular failure due to an underlying lung pathology. The left atrium is divided from the right atrium by an interatrial septum. It has a relatively thicker wall compared with the right atrium, so that it can adapt to higher pressures of blood entering the chamber from the lungs. Oxygenated blood will arrive into the lungs into scratch that oxygenated blood will arrive into the left atrium from the lungs in the posterior part of the cavity via the pulmonary veins. The pulmonary veins entering the left atrium have no valves. Therefore, they can easily see backflow of blood through them back into the lungs. Instead of pulmonary valves, or instead of valves on these vessels, pectinate muscles extend from the atria into the pulmonary vein and exert a sphincter-like action, usually to prevent backflow of blood during contraction of the atria under healthy conditions. The normal filling pressure of the left ventricle is between 4 and 12 millimeters of mercury. These pressure values are important for you to know, so please remember the pressures that are common to each chamber. Oxygenated blood is ejected out of the left atrium through the mitral atrioventricular valve, which has only two cusps. Therefore, it is a bicuspid valve, and blood will cross that to enter the left ventricle. A clinical tip to remember here is that insufficiency of the mitral valve will cause blood to backflow from the left ventricle back into the left atrium, and this can also be called regurgitation. So therefore, blood will accumulate in the left atrium and elevate the left atrial pressure, which means that there will be difficulty filling the lungs or filling the left atrium with blood returning from the lungs. These chronically elevated pressures alter the integrity of the atrial wall and predispose the individual to develop a quivering of the atrial wall. This quivering is known as atrial fibrillation. So instead of the chamber making a good, nice contraction like I'm showing, it actually quivers without a functional contraction. Again, that is called atrial fibrillation. Because the muscle no longer is capable of making nice, smooth contractions, there is potential for development of blood clots within the left atrium. If such a clot is formed, they can break off and travel to the brain, causing strokes, or it can cause other downstream effects of thromboembolism. The almost conical left ventricle is longer and narrower than the right ventricle. The walls of the left ventricle are approximately 3 times thicker than those on the right, and the transverse aspect of the cavity is almost circular. In contrast to the inflow and outflow orifices of the right ventricle, the inflow and the outflow of the left ventricle are adjacent to one another. It is separated only by the anterior leaflet of the mitral valve and the common fibrous ridge to which it and the left and posterior cusps of the aortic valve are attached. The interventricular septum is a division that is the wall separating the left ventricle from the right ventricle. The left ventricle receives oxygenated blood from the left atrium, which has arrived from the lungs, and it enters the left ventricle, which is therefore the inflow tract of the left ventricle via the mitral valve. So the mitral valve is situated between the left atrium and the left ventricle and allows the blood to enter the left ventricle. The left ventricle ejects the blood that it has received through the aortic valve into the aorta and thereby to the peripheral systemic circulation. Therefore, we can summarize that the inflow of the left ventricle is the mitral valve and the outflow is the aortic valve. Normal systolic pressures within the left ventricle are 80 to 120 millimeters of mercury, and the diastolic pressures are about 4 to 12 millimeters of mercury. One more time, these values of pressures within cardiac chambers is an important concept. Because of the elevated pressure within the left ventricle, the wall thickness of the left ventricle is greater, as we just discussed. A clinical tip on the left ventricle is that under pathologic circumstances, the walls of the left ventricle further thicken. We call it hypertrophy. It is seen in hypertension, heart failure, aortic stenosis, and any other condition that makes the left ventricle have to beat harder. This is because of increase in the resistance that it has to overcome to push the blood into the systemic circulation. This resistance is called afterload, as we will discuss later on. The pathologic thickening leads to also a reduced filling capacity of the left ventricle, resulting in the amount of blood coming in to be reduced, and therefore the amount of blood that goes out, called the cardiac output, to be also reduced. Let's now talk about the heart valves. There are four heart valves and they provide unidirectional flow. Therefore, under normal circumstances, blood cannot go in the wrong direction inside the heart because of the presence of the valves. There are two valves between the atria and the ventricle, therefore they are called atrioventricular, and these are the tricuspid valve on the right and the mitral valve with two leaflets, therefore it is called bicuspid valve on the left, between the left atrium and the left ventricle. The semilunar valves lie between the ventricles and the arteries through which it sends the blood out. So between the ventricle and their outflow tract. They are named based on their corresponding blood vessel into which it sends the blood out. Therefore, we have a pulmonary or pulmonic valve on the right, and that ejects the blood from the right ventricle into the pulmonary artery. On the left side, the left ventricle ejects the blood from the ventricle into the aorta through the valve called the aortic valve. Flaps of tissue which cover these valves are called leaflets. Therefore, these leaflets, or they're also called cusps, and they are the tissues which restrict or guard the heart valve openings. The right atrioventricular valve has three cusps and therefore it is called tricuspid, whereas the atrioventricular valve on the left, which is the mitral valve, has only two cusps and therefore it is called bicuspid. These leaflets are attached to the papillary muscles of the myocardium by these structures, long string-like structures called chordae tendineae. The primary function of the atrioventricular valves is to prevent backflow of blood into the atria during the contraction of the ventricles, or what we call cardiac systole. And the semilunar valves prevent backflow of blood from the aorta and the pulmonary artery back into the ventricles during the relaxation phase of the heart, which we call diastole. Opening and closing of each valve depends on pressure gradient changes within the heart created during each cardiac cycle. An initial disturbance of valvular function may be picked up By auscultation or using a stethoscope over the chest, over the heart areas. There are specific areas where the stethoscope need to be placed to pick up sounds from specific valves. When blood flows through these abnormal valves under pathological conditions, then it produces a sound which we can pick up through a stethoscope. These abnormal sounds indicate turbulent flow instead of streamlined flow, and these are called murmurs. There are many different types of murmurs, some of which you will learn in auscultation. It must be emphasized that the identification of a murmur would warrant the need for additional testing by a specialist, including the tests for echocardiography, to accurately diagnose the pathology within the particular valve. For physical therapists, that would mean that if you hear a valve, you should at least communicate with the physician to follow up. The heart has contractile elements, but it also has electrical elements. There is a conduction system in the heart where electrical impulses will auto-generate and travel through electrical tissue within the heart. This conduction system features a pacemaker node where the signals normally arise. The electrical impulses in the conduction system in the heart will normally arise at the sinoatrial or SA node, and this electrical impulse which arises at the sinoatrial node is called the sinus. The SA node is located at the junction of the right atrium, right here. Is located at the right atrium and the superior vena cava. The P cells of the SA node are the sites for impulse generation. Consequently, the SA node is termed the pacemaker of the heart, as it makes or creates the impulses that pace the heart. The normal pacing ability of the SA node is between 60 and 100 beats per minute at rest. The impulse generated at the SA node travels down one of the three internodal tracts to the atrioventricular node. So what this is there is a single node, and then there are three tracts, 1, 2, and 3, that arise from the SA node and carry the impulse to the atrioventricular node. These are called internodal tracts. The three conduction pathways that exists between the SA node and the AV node include an anterior tract of Bachmann, so this is in the front, a middle tract of Wenckebach, which is spelled as Wenkebsch, and a posterior tract of Thorel. So those are your three internodal tracts: an anterior tract of Bachmann, a middle tract of Wenckebach, and a posterior tract of Thorel. The three pacemakers are shown in circles in this image. The AV node is located at the inferior aspect of the right atrium, near the opening of the coronary sinus and above the tricuspid valve. Behind or posterior to the AV node, there are many parasympathetic autonomic ganglia that serve as receptors for the vagus nerve, and the stimulation by the vagus, being a parasympathetic, is to slow the cardiac cycle down. The major function of the atrioventricular node during each cardiac cycle is to slow down the cardiac impulse that has arrived there from the SA node, and it does so because it has a very high resistance. So the signal slows down to get through the AV node. The physiologic reason for having a slowed down signal transmission through the AV node is to mechanically allow time for the ventricles to fill during this period. So the signal arises from the SA node, arrives at the AV node, and slows down. This signal has already triggered the atria to contract. However, the ventricles are still relaxed because the signal has not gone into the ventricle, and therefore during this period the ventricle is still filling with blood arriving from the atria. The conducting fibers from the AV node will converge together to form a bundle. This bundle of fibers is called the bundle of His. His is capitalized. So the bundle of His will carry the impulse into the ventricles. This bundle was first described by a physician called Dr. His, and it's named after him. The bundle of His appears as a triangle of nerve fibers within the posterior border of the interventricular septum. Lower down, this bundle will split and it will bifurcate to give rise to the right and left bundle branches, which carry the impulse to the right and left ventricles respectively. The right bundle branch is thin with relatively fewer fibers, but um, anterior, the left is much thicker. Uh, so the left bundle branch arises perpendicularly and descends into two branches or fascicles. The left bundle, these two fascicles, one is anterior, so the left anterior bundle branch crosses the left anterior papillary muscle and proceeds along the base of the left ventricle towards the aortic valve. The left posterior bundle branch will advance backwards or posteriorly through the posterior papillary muscle towards the posterior inferior left ventricular wall. Now, both these branches, both the bundles will terminate or transition into a network of nerve fibers called the Purkinje fibers. These fibers extend from the apex of each ventricle and penetrate the heart wall to the outer myocardium. So the nerve supply of the muscle of the heart is from the inside to the outside. So electrical stimulation of the Purkinje fibers causes mechanical contraction of the ventricles. It may be important to appreciate that normal electrical conduction through the Purkinje fibers or through the heart will allow for appropriate mechanical activity and maintenance of cardiac output to sustain activity. An alteration in the conduction pathway will alter the mechanical activity of the heart and thereby reduce cardiac output. So this electrical signaling system is evaluated by the test called the ECG. Therefore, you can expect that an ECG examination is necessary to evaluate and differentially diagnose one of the causes of exercise intolerance, because there is reduced cardiac output due to abnormal electrical transmission. So there are various scenarios where a physical therapist will need to know whether an alteration of this signaling mechanism is responsible for certain things like falls. I also wanted to talk about the law of the fastest node. The sinoatrial node produces the fastest signal, the 60 to 100 beats per uh, minute under resting conditions. Now, there are other nodes within this conduction system that are also capable of generating impulses, and that includes the AV node and the Purkinje fibers. However, the AV node and the Purkinje fibers produce impulses which are significantly slower than the sinoatrial node. Therefore, the sinoatrial node takes precedence over the AV node or the Purkinje fibers and suppresses that signaling mechanism. This is called the law of the fastest node. Therefore, under normal resting conditions, the SA node supervenes and is called, therefore, the master node. In electrical disturbances, this may be altered when the sinoatrial node no longer functions appropriately. If the signaling mechanism shifts or the pacing mechanism shifts to the AV node, since the AV node sits on the junction between the atrium and the ventricle, it is called a junctional rhythm and can be also picked up by the ECG. Now, although the SA node and the conduction pathway have an intrinsic rate of depolarization, which results in the contraction of the myocardium, yet the autonomic nervous system influences the rate of impulse generation, contraction, relaxation, and strength of contraction. So all these four elements, um, impulse generation, contraction, relaxation, and strength of contraction, is under autonomic control. This autonomic nervous transmission creates changes in the heart rate and contractility, strength of contraction, to allow adjustments to cardiac output, which is necessary for the changing metabolic demands of the body. A cardiac plexus contains both sympathetic and parasympathetic nerve fibers and is located anterior to the tracheal bifurcation, which is the position we call the carina. So the tracheal bifurcation is the point where the trachea splits into two. That is the tracheal bifurcation. The position is called the carina. So there is a cardiac plexus that lies in front or anterior to the carina. The cardiac plexus receives parasympathetic input from the right and left vagus nerves, and subsequently nerves branch off the plexus, follow the coronary vessels, and innervate the SA node and other components of the conduction system. There is relatively less parasympathetic innervation to the ventricles, resulting in a sympathetic dominance on ventricular function. Vagal stimulation is inhibitory on the cardiovascular system, as it is in many other conditions in the body. So it slows down the cardiac cycle. Therefore, you can expect a reduced heart rate, reduced blood pressure, and so on. The neurohormone which is responsible with parasympathetic stimulation is acetylcholine, as it is in most parts of the body, or most parts of the autonomic system. The sympathetic input to the plexus comes from the sympathetic trunk in the neck. Cardiac nerves from the cervical and upper 4 to 5 thoracic ganglia feed into the cardiac plexus. The sympathetic stimulation releases excuse me, catecholamines, which are epinephrine and norepinephrine, that interact with beta adrenergic receptors on the cardiac cell membrane, causing an excitation of the cardiovascular system. This is evidenced by an increase in heart rate, increased contractility through a greater influx of calcium into the myocytes, and increased blood pressure with a shortening of the conduction time through the AV node and an increase in the rhythmicity of the atrioventricular pacemaker fibers. The sympathetic nervous system stimulation is cardioexcitatory. Therefore, it increases heart rate and the force of contraction along with the rate of contraction. This is required for the classic sympathetic response of fright, fight, or flight. Conversely, the parasympathetic stimulation is cardioinhibitory and slows down the heart rate and contractility. It is important to remember that under some surgical pathologic conditions, the heart no longer retains the autonomic innervation. This happens when there is a heart transplantation surgery. In those patients, there is no further autonomic innervation. Therefore, the heart it will become erratic and will have no set rate or rhythm. This is why a cardiac surgical transplantation will also be accompanied by the placement of a pacemaker that regulates the heartbeat. There are two great arteries arising from the heart, the aorta and the pulmonary artery. The ascending aorta arises at the base of the left ventricle and is approximately 2 inches long. And from the lower border of the third costal cartilage at the left of the sternum, it passes upward and forward towards the right as high as about the right second costal cartilage. The aorta exhibits three dilatations above the attached margins of the cusps of the aortic valve at the root of the aorta. These dilatations are called the aortic sinuses of Valsalva. The coronary arteries open near these aortic sinuses of Valsalva right above the point of the aortic valve where the blood has come out of the left ventricle, and it is situated one each on each side. Three branches typically arise from the upper aspect of the arch of the aorta. So as the aorta goes up and arches, there would be about three branches from there, and these are called the brachiocephalic trunk, also called the innominate artery, the left common carotid artery, and the left subclavian. The openings of the coronary artery and will block blood from entering into the arteries when the aortic valve is open. Therefore, the coronary arteries during the process of cardiac systole will not receive blood. So no blood goes into the coronary arteries during the heart's contraction. Therefore, the part of the cardiac cycle when the cardiac arteries, the coronary arteries that is, receive their own blood is during the resting phase of the cardiac cycle, which is diastole. And this is the time when the aortic valves are closed, and not only is the heart able to get blood better at that time, it is also enhanced by the fact that whatever blood was climbing in the arch of the aorta but did not quite make it to the top will drop down and then be forced into the coronary arteries. This is something that is utilized in ischemic heart by circulatory support systems to force more blood into the coronary arteries. Now let's talk about the pulmonary artery. The pulmonary artery, the trunk of the pulmonary artery rather, runs upwards and backwards from the base of the right ventricle. It is approximately 2 inches in length as well. At the level of the fifth thoracic vertebra, it splits into right and left pulmonary arteries. So about the fifth thoracic vertebra, it splits into right and left thoracic artery. The right pulmonary artery runs behind the ascending aorta, the superior vena cava, and the upper pulmonary vein, but it lies in front of the esophagus and the right primary bronchus to the root of the lung. The left pulmonary artery runs in front of the descending aorta and the left primary bronchus to the root of the left lung. It is attached to the arch of the aorta by the ligamentum arteriosum. And a clinical tip is that this is the area where we often see a blood clot that travels from somewhere and attaches to the split and is situated on both sides of the bifurcation. This is called a saddle embolus. A saddle embolus is life-threatening and involves significant medical intervention to ensure life to continue. That's it. Let's now look at the arteries that supply the cardiac myocardium itself. These are the coronary arteries. There are two main coronary arteries, the right and the left. The right coronary artery arises from the right anterolateral surface of the aorta and passes between the auricular appendages of the right atrium and the pulmonary trunk, typically giving off a branch to the sinus node and yielding 2 or 3 right anterior ventricular rami as it descends into the coronary sulcus to come around the right acute margin of the heart into the posterior aspect of the sulcus. As the right coronary artery, or RCA, crosses the right margin of the heart, it gives off a right acute marginal artery before continuing as far as the posterior interventricular sulcus, which it usually turns to supply the diaphragmatic surfaces of the ventricles as the posterior interventricular artery. In approximately 70% of the hearts, an atrioventricular nodal artery is given off from the RCA just before the posterior interventricular artery. Now let's look at the most important in terms of myocardial function, the left coronary artery. It is the bigger of the two and originates from the left anterolateral surface or aspect of the aorta and splits into two major branches, the anterior interventricular and the circumflex arteries. The anterior interventricular, which is the first of the two, or also called the LAD, left anterior descending artery, traverses the anterior interventricular groove to supply the sternocostal aspects of both ventricles. In its course, the anterior interventricular artery gives off right and left anterior ventricular and anterior septal branches. The larger left anterior ventricular branches vary in number from 2 to 9, with the first being designated the diagonal artery. Approximately 70% of the left ventricle is fed by the LAD. The circumflex artery runs in the coronary sulcus between the left atrium and the ventricle, crosses the left margin of the heart, and usually continues to its ending. The termination or the ending of the circumflex artery is just short of the junction of the right coronary artery and the posterior interventricular arteries. In many cases, as the circumflex artery crosses the left margin of the heart, it gives off a large branch that supplies this area, the left marginal or obtuse artery. The right coronary artery is the primary supply route for blood to the majority of the right ventricle and the inferior and posterior portions of the left ventricle. In addition, specialized conduction tissues within the right atrium, including the SA node and the AV node, receive blood supply by the right coronary artery. The LAD, on the other hand, supplies blood to the anterior and septal aspects of the left ventricle, and the circumflex artery supplies blood to the lateral aspects of the left ventricle. Occlusion of the coronary artery produces an infarction, which is basically death of the myocardial cells in a defined region of its supply within the heart. The right coronary artery occlusion causes inferior or posterior infarctions and affect the functioning of the SA node in the right atrium. The left anterior descending occlusion produces an anterior septal infarction also, and this is what we call the widowmaker, whereas the circumflex occlusion are responsible for generating lateral wall infarctions. Distribution of blood supply within the heart is variable from one individual to another because of the presence of collateral circulation involving the formation of new blood vessels, which we call angiogenesis, in areas of the heart that are partially occluded. Shifting focus, looking now at the pulmonary vein. Unlike the systemic veins, the pulmonary vein has no valves. They originate in the capillary networks and join together to ultimately form two veins, a superior and an inferior pulmonary vein, one from each lung, which opens separately into the left atrium. Thereby, you can see four openings in the left atrium with no valves at those junctions, draining the blood from the lungs into the left atrium. This blood, for most intent and purposes, is oxygenated. This makes the pulmonary veins the only veins in the body that carries pure blood. Thereby, it is important to remember that the way we classify arteries and veins is that arteries take blood away from the heart, whereas veins bring blood back into the heart. The vessels that bring the blood back to the heart are the vena cavas, and the vessels that drain the heart muscle itself are the cardiac veins. There are two vena cavas, the superior and the inferior. The superior vena cava is approximately 3 inches long from the termination in the upper part of the right atrium, opposite the third right costal cartilage, to the junction of the two brachiocephalic veins. The superior vena cava drains the head and the neck into the right atrium. The inferior vena cava extends from the junction of the two common iliac veins in front of the fifth lumbar vertebra, and passes through the diaphragm to open into the lower portion of the right atrium. The vena cava, like other veins in the body, do not have any valves. So, to be more clear, the vena cavas do not have valves, whereas other veins, especially the lymph veins in the body, have valves in them. The cardiac veins can be categorized into three groups: the coronary sinus and its supplying veins, the anterior cardiac veins, and the Thebesian veins. Most of the veins of the heart drain into the coronary sinus itself, which runs into the posterior aspect of the coronary sulcus and empties through the valve of the coronary sinus, uh, a semilunar flap, into the right atrium between the openings of the inferior vena cava and the tricuspid valve. The anterior cardiac veins are fed from the anterior part of the right ventricle. They originate in the subepicardial tissue, crossing the coronary sulcus as they terminate directly into the right atrium. The right marginal veins runs along the right border of the heart and usually opens directly into the right atrium. Occasionally, it may join the small cardiac vein. The Thebesian vein is also called the veni cordis minimi. It varies greatly in their number and size from person to person. These tiny veins open into all the cavities of the heart, but are most numerous in the right atrium and the ventricle, and are found occasionally in the left atrium and are rare in the left ventricle. Let's now look at the circulatory schematics of the heart. You will see that the veins are represented in blue and the arteries are represented in red. The blood returns into the right atrium. Um, you see here, the blood returns into the right atrium from the superior vena cava and the inferior vena cava, and then it goes through the tricuspid valve into the right ventricle. The right ventricle then contracts and sends the blood up the pulmonary valve into the pulmonary artery, and then it goes to each lung by splitting. This is the location where a saddle embolus forms, uh, and that is a pathological situation. Um, Once the blood goes to the uh, lungs, It exchanges carbon dioxide and oxygen, and oxygenated blood will be returned through the four pulmonary veins back into the left atrium. This is nearly fully saturated, or rather, the blood returning into the left atrium from the lungs is nearly fully saturated with oxygen. However, the veins of the heart, including the coronary sinus that drains into all the chambers, especially the ones that drain into the left atrium directly, will admixture a little bit of venous blood into the oxygenated blood. The blood arriving in the left atrium will go through the mitral valve in the left ventricle, and then on contraction or systole of the left ventricle will push it out through the aortic valve in the aorta. And you can see the three divisions of the aorta shown here, or the arch of the aorta shown here, and correlate with previous slides and the textbook. The vascular endothelium is the lining of the blood vessels. So endothelial cells are also called the endothelial lining, and they have the ability to adjust their number and arrangement to accommodate local requirements. The endothelial cells can stick together really tightly, or they can move around so that it creates just enough gap for things like water to come out of the blood vessel or come back in. Typically, the proteins of the blood will not leave the vascular endothelium. The endothelial cells serve several important functions, including filtration and permeability, vasomotion, clotting, and inflammation. The disease that is responsible for decreasing blood supply to many organs is called atherosclerosis. Atherosclerosis is initiated through the dysfunction of the endothelial cells, and it is evidenced by endothelial cells that are extensively permeable to fat cells and white blood cells. The body's circulation is shown on this image. The systemic circulation is the circulating blood to the body's organs and tissues, whereas the pulmonary circulation is the circulation that goes to the body, to the lungs. In the systemic circulation, oxygenated blood is ejected out of the heart and flows through the aorta into the systemic arteries. These arteries branch into smaller blood vessels, and these smaller blood vessels are called arterioles, which further branch out into smaller vessels, which are called the capillaries, and the capillary is the primary site where the exchange of nutrients and gases take place. The deoxygenated blood from the capillaries enters venules that join together to form larger veins that return blood back to the right heart and the lungs. Blood vessels have three layers. The innermost layer of the blood vessel is called the intima. Now you can imagine that the walls of the blood vessels are referred to as jackets. In other words, or in Latin, that would be tunic. So the inner wall or the innermost layer is the intima. So tunica intima. Similarly, the middle layer is tunica media, and the outermost layer is the tunica adventitia. The different characteristics of the blood vessel in different parts of the body is based on the number of contractile or non-contractile muscle cells or the presence of elastic fibers in these layers of the blood vessel. So, talking now about the arteries, the walls are composed of elastic and fibrous connective tissue and smooth muscles. Anatomically, these arteries can be categorized into two types depending on the structural uniqueness along their walls. There are the elastic arteries, which include the aorta and the pulmonary trunk, which have thick tunica media, which contains a lot of elastic fibers more than smooth muscle fibers or smooth muscle cells. This allows for the vessels to stretch out as blood is ejected out into these arteries. During diastole, the elasticity of the vessel, imagine that the blood vessel or the circular blood vessel is stretched out. So that means there are elastic fibers that allow the stretch to occur. So when the heart goes into rest cycle or diastole, this blood vessel collapses back because of the presence of those elastic fibers. This recoil of the blood vessel maintains the blood pressure within the vessel as it transmits the blood further away from the heart. This is the diastolic pressure that we record using a sphygmomanometer. The muscular arteries are present in medium and small arteries where there are more smooth muscles within the middle tunica media. This is the difference between elastic arteries and muscular arteries. Whereas in elastic we have more elastic fibers, the muscular arteries have more smooth muscles in the tunica media. Therefore, these arteries have the ability to constrict, which we call vasoconstriction, constriction of the blood vessel, or dilate, which we call vasodilation or enlargement of the diameter of the blood vessel. So these actions can occur because of the presence of the smooth muscles that control the blood flow to the periphery. These smooth muscle cells are under the control of the autonomic nervous system through the presence of the alpha receptors. As the artery becomes more distal, a greater amount of smooth muscle is found. Arterioles have primary smooth muscle along their walls, enabling their diameter to be altered significantly as needed. Arterioles will empty into the capillary beds. The density of the capillaries within a capillary bed is greater in active tissues such as muscle. Exchange of nutrients and gases will occur in this capillary bed. Refer your book in figure 120, which depicts the major arterial tree within the human body as shown in the image also on this slide. Now, veins are the thinner blood vessel conduits. Veins are classically described as structures that carry impure blood. A better definition would be for veins is blood that returns back towards the heart is carried by these conduits called veins. This is in direct comparison with the arteries which carry blood away from the heart. Now, compared with arteries, veins have thinner walls and a larger diameter. Veins also have very low amount of elastic tissue, and therefore they are not distensible, they do not stretch. In the lower extremity, veins have valves, as I was mentioning earlier in this presentation. These valves assist with the unidirectional flow of blood back towards the heart. So veins, as it coming up against gravity, the valves prevent the blood returning backwards or down towards the bottom. So blood is transferred back to the heart through muscle pump activity, which is like a milking effect on the veins. So the muscle pump, especially the soleus in the lower extremity, which has large venous sinuses, which store the blood until muscle action compresses the soleus against the back of the tibia and milks the veins up towards the heart. Now, patients who have valves which are not functioning, we call them incompetent valves. When people have incompetent valves, then blood drops down in the wrong direction and pools, and thereby makes the veins appear engorged and tortuous. Tortuous means very zigzaggy. These are called varicosities, and these are clearly visible and rather ugly, seen in the lower extremities. Another important clinical tip is people who are on long time bed rest are likely to develop a thromboembolic event, which is we refer to it commonly as deep vein thrombosis. And this occurs from a lack of muscle activity, resulting in pooling of blood and clot formation within the venous vasculature. I would like to close this presentation with a discussion on a terminology called the shunt. You just reviewed the normal schematic of circulation in the heart. The normal blood flow in the body can be stated to be from the arterial side to the venous side. That is the usual course of blood flow. Blood always will go in a normal person from the oxygenated towards the deoxygenated side, therefore from the artery to the vein. In the heart itself, the arterial side is represented by the left side of the heart, and the venous side is represented by the right side of the heart. The blood flow, therefore, can be stated to be from the left side of the heart to the right side of the heart by taking into account the entire circulation from the left side of the heart into the arteries, down to the capillary bed, down back to the veins, and then inferior vena cava and back to the heart. However, under pathological or congenital malformation situations, this blood flow can change. If the blood flow changes from the artery to vein to the artery, this is called a shunt. A shunt is a pattern of blood flow in the heart that deviates from the normal flow circuit of the circulatory system. So as I mentioned, it may be left to right, which is the systemic circulation that we just talked about. However, there is a right to left normal circulation, which happens when the blood goes from the right side of the heart to the lungs, and then it returns to the left side of the heart. Now that is a pulmonary to systemic shunt, and that is also normal. However, under certain conditions, like for example, if there is a hole in the heart, in the walls, in the septum of the heart, blood flow may change from the right to the left or left to the right without going through the normal body circulation. All these abnormal flow patterns are called shunts. Not all shunts are bad, but if a shunt develops later in life, it typically signifies a poor medical outcome. Additionally, a shunt is also required if a person is born with certain congenital anomalies of the heart. These shunts have to be surgically created to allow the baby to survive. So the term shunt is an abnormal blood flow. It may be normal or abnormal, and there are several different forms. And the purpose of this particular slide is to just inform you as to the terminology of a shunt, which refers to an abnormal blood flow pattern. This slide gives you a video of the shunting of blood in the heart. And I encourage you to observe this, and this is on your own, and you do it from your own presentation that has been provided to you. The the shunts that we mentioned were primarily the ones we see in the heart. There can be, however, shunts in the peripheral vasculature as well, and it indicates flow bypass out of the general circuit. There can be multiple reasons for vascular shunts, but the most common one, perhaps, is the ones you will see that are created surgically to facilitate in renal failure, the performance of hemodialysis. And that brings us to the end of this presentation. Here are some references. I strongly urge you to read the textbook, and that is the first place you should start at. Thank you very much. Thank you for your attention, and please use the chapter links that will be provided in this video as as a mechanism to jump to the proper place within this presentation.